Welcome to the Healing Grove podcast. I'm Dr. Kristin Ryman, an integrative holistic family physician, author of Life After Lyme, and host in this virtual space of learning, healing, and growing. I believe humans are like trees, and our physical limb is only one of many. Health on all limbs of the tree, emotional, conceptual, social, spiritual, is absolutely required for the whole tree that is you to be vibrantly well. I created the Healing Grove podcast as a place to showcase some of the world's best integrative and holistic medicine, to expose you to transformative tools and mindset shifts for all limbs of your tree. I hope you enjoy our conversation in the Healing Grove today as much as I enjoyed having it. Here we are. A lot has happened to you since our last conversation, Meghan Tveit, but why don't I let you tell it? Where have things been since we last talked?
Oh my gosh, so many things since we last talked. So we last talked, I finished my penultimate rotation, which was internal medicine, and we debriefed on that. And then now I'm on the other side of not only my final rotation of medical school, but also step 2. So my final rotation was family medicine. And then after that, I took some time to prepare for our last board exam of medical school, which is called step 2. And step 2 is basically an exam that covers every rotation, every clinical experience that you could have had. And it is a 9-hour-long exam to send you off into residency for 4th year, which then leads to residency. So that is where we are at in this world.
So a lot has happened. So let's start by talking about, I want to get into family medicine because, you know, that's a little near and dear to my heart. But I also I want to provide some context for this system for people who don't understand how the medical training system works. So tell us about the 3 steps and what your study habits looked like for the first 2, since that's how far you've gotten.
Yes. So for GW, each school does their curriculum a little bit differently, but they all follow a general pattern, which is your first year to year and a half is your preclinical years. So you're in the classroom, you're studying, you're taking exams. And at the end of your preclinical year or year and a half, you take step 1, which basically is your ticket to start your clinical years. Your clinical years are where you're doing all the rotations. So we started this podcast many months ago, a year ago, where I started my first clinical rotation in pediatrics. So over the course of this entire year, I've been going through all of the different clinical rotations. And I finished those about 4 weeks ago. And at the end of your clinical year is when you take step 2. Step 2 is going to be an exam that covers, like I said, all of those clinical years or clinical experiences. And then 4th year of medical school is really going to be your opportunity to start applying to residency, taking electives. It's kind of like that time where you get to really explore deeply into the things that you're most interested in now that you've had kind of a more broad foundation through your clinical rotations. And then in residency is when you take step 3, which is something that I have no experience with yet. So I can't speak too much on, but I believe you take it after your first year of residency. So that will be in the future for me.
And how did step 2 compare to step 1 for you in terms of both the experience of taking it and the content and how you studied for it?
Yes. Okay. So step 1, like I said, you take after your preclinical years, and it is the beauty of step 1 is it's pass fail now. It has not always been. I think I'm the 2nd year. Yeah. I am only the 2nd year that has gone through step 1 as pass fail exam.
Wow.
Which is a blessing and a curse. It's a blessing because it's pass fail. And so as long as you work hard, you're likely to pass. It's a curse because it puts a lot of pressure on step 2, because that's really the only quantitative measurement that residencies are going to have in terms of evaluating you.
Yeah.
So, and I think also whenever I say pass fail, I think people think, oh, that sounds like you're fine, it's easy. But I really like to lay out the study days. My step 1 and my step 2 study days looked nearly identical. They the type of person that likes to wake up early and get things going, get the show on the road. My brain is highest functioning between the hours of around 6 to around 2. And so I really try to capitalize on that. I wake up around 5. The past 6 weeks that I was studying for this exam, I was waking up at 5:40, and I would start studying by 6 after my like little stretching routine. And other than like walks and little breaks, like mind breaks, I was studying from around 6 to 3 p.m. I would exercise between the hours of like 3 to 5. And then I would do a little bit of review before dinner. And then after like 7, when I sat down for dinner, I didn't study anymore. So it was 6 a.m. to 7 p.m. with an extra like 2-hour exercise break and a little bit of a break for lunch. So that was what my days looked like, Monday through Saturday, 6 days a week. I took a practice exam every Saturday and I took Sundays off. And it was super routine, down to its core. And that is consistent with a lot of people's experience. I don't think I'm like unique in how I approached it. I think it's generally speaking, it's an exam that you have to commit a lot of hours to in order to do well. And kind of I wanted to do well and perform with a score that's going to allow me to kind of have a little bit more freedom in where I want to go to residency, because I am a bit specific about where I want to end up. So I was also having that kind of added pressure too.
And how long do you wait for your scores to get back?
It's so funny because that was the first question, or not the first question, but that was one of the first questions that your son, Mahlon, had asked me as I was leaving the exam, crying my eyes out, being like, thank God this is over. Oh my gosh. And after like the congratulations and the kudos, and one of his questions was, well, when do you find out your score? And I was like, honestly, I have no clue. I have zero idea. It could be tomorrow. It could have been at the thing and I just didn't know. It could be tomorrow. It could be in a month. I don't know. All I know is that is out of my control. And right now, all I want to do is live in this moment of it being done, and that will come later. It did come around a couple days ago, and I found out you could find out between 9 days and 21 days after your exam. So it's a range. I think I'll just get an email in my inbox when it has been processed, and probably have a mini little heart flutter palpitation situation, and then figure it out.
Wow. Okay. Well, I'm sort of intrigued by this notion that you studied the same amount of time and intensity for both, because I remember in my day, we used to say step 1 is 2 months of study, step 2, 2 weeks of study, and step 3 is a number 2 pencil.
Okay, you got me. My days looked identical. The duration by which I studied was shortened. Mine was probably not half. It was probably 2/3. I did it in a bit of a strange way. But I studied like 8 weeks for step 1 and 4 weeks for step 2. So it is half. My days themselves looked very similar, but yeah, the duration I was studying is definitely shorter for step 2.
Okay, fair enough. All right. All right. So let's go back to your last rotation in your 3rd year. And to be clear, in case anyone missed this, you have a whole other year. You're 75% of the way through your training as a medical student. And this next year is somewhat different from the last year because you've already kind of grinded through all the, what do they call them? Shelf exams and all of the kind of rotations that are the basics that everybody goes through. And now you're in the kind of free flying elective time. But let's talk about family medicine, because family medicine is, of course, my specialty, and it's what I chose to do. You're not choosing to do it, which is fine, but I want to hear what your experience was like in family medicine. What is the world of family medicine these days as a medical student rotating through?
Well, I could first say I know why you are so good at it, and you chose this route, because I really did feel like it was the perfect opportunity to really get to know people and like their situation and their stories at a deeper level than I had experienced in any other rotation. With the caveat, I was 100% of the time feeling so rushed, so incredibly rushed, that I say that it was an opportunity to create those connections. However, I actually felt very limited in my ability to do that because of the time constraints. So I had 15 minutes to see a patient, do a history and physical exam, come out of the room, present the patient to my attending, go in the room with my attending and myself, and talk to the patient about the assessment and plan for their appointment. So that all of those components happened in 15 minutes. So you could imagine I was really only seeing the patient for like 8-ish minutes before I was having to get out of the room and tell my attending my findings or why the patient was here and what I think we need to do next. And unfortunately, 8 minutes is not a sufficient amount of time to build a connection or to learn about a patient's history or what they're dealing with in terms of whatever they're coming into the doctor for that day. So that to me was the hardest part about it. I felt like I just wanted more out of each encounter that I wasn't really able to get, because if I was the person, like there were definitely a couple times I come out of the room and my attending's like sitting there like tapping his fingers like, okay, you were supposed to be out like many minutes ago. And then the whole rest of the encounter just felt rushed, and then you're behind and the patients get angry, and it turned into a bit of an issue if I was late. So I always just knew that, like, unfortunately, to the patient's discredit, I needed to just be quicker in order for everything else to run smoothly.
Well, and I mean, I think there's something inherently broken or unsustainable about a system in which each person gets 15 minutes for their entire visit. Like, they're probably every 15 minutes.
Yeah, every 15 minutes, full day.
Minutes, someone arrives expecting it to get the doctor's full attention or the team's full attention for their 15 minutes. Usually they're an hour late, or, you know, usually they're some degree late. And so they're getting into their 15-minute slot grumpy with an hour of waiting or 45 minutes of waiting under their belt. And then a lot of that 15 minutes is taken up by, admin stuff, the nurses taking vitals and it's important stuff. But the point is, all this important stuff that happens really should have more time than 15 minutes. And because it doesn't, everyone feels like a failure because you're never on top of it. I mean, I think this is the case for most standard practice, family practice, primary care offices right now. Unless they're doing something really different and scheduling in such a different way, everyone ends up feeling like, disappointed. Doctors, med students, nurses, patients.
Yeah, no, I could tell it was definitely frustrating for them as well. And it's tough because if you lengthen the patient time and say, okay, we're only going to schedule every 30 minutes, then patients aren't going to get appointments for months and months out. So unless you have more providers, it's such a systems level problem. I don't even really know how to fix it, other than I do think that you need more time with your patients, but then it's just going to push everything back.
Yeah. I don't have a quick answer for you.
Yeah. The other thing I will say, and I'm curious what you think about this. This is a fairly specific observation, but I always found it very interesting how patients would come in for just their annual physical exam. And then that is the day that that labs are ordered. And then the patient will go off and get their labs drawn. But then that was the lab results were not part of the visit, and they were just kind of like, okay, they're going to be on LabCorp, and then like I'll let you know if there's anything crazy, maybe, or like hopefully you'll figure it out if there's something crazy and come talk to me. And I always was like, it seems like it would be such a more productive use of our time if you came to the appointment having already got your labs drawn, because then you're actually able to like have such a more informed conversation at that point. I don't know. I just observe that every time. I'm like, oh, he's curious about his cholesterol level because his cholesterol was high in the past. But how are we having a conversation about lifestyle modifications and any like adding medication if we actually don't know what his cholesterol is today?
Yeah. No, I think you raise a really important point. And I think in a lot of systems, what places have done is create teams of people to take care of patients and to kind of do that pre-work. So who's on the schedule for next week? Like in the best of cases, you know who's coming in, you know why they're coming in. You also know what questions they might have and whether there are gaps in their lab work or the studies, or you don't have the report for things. And so people can be on top of that, getting them in, getting the table set really for the person when they come in. The other answer to that is just seeing people more often, right? Like having frequent continuity so that you say, look, you're here for your annual, and yes, here are all the 5 items that we need to kind of check in on. And there's going to be we're going to need to come back for another visit and talk through all the results of all this. And and I think because systems are so overburdened often and just understaffed, and it's, as you said, it's really hard to get people seen and in in a timely way. I think a lot of doctors end up just, reviewing the labs during their admin time and then shooting off an email or having the nurse call the patient back and say, tell them to start this medication, or tell them that everything's fine, nothing to change. Right. And also what happens is that now everyone has access to their results. This wasn't the case when I was in residency. It was just kind of starting that there was like a portal and patients could get on the portal and see their lab results and then, have the opportunity to freak out because, oh my God, what does this mean? And then people are Googling all these terms and trying to figure out if what they have is, cancerous or really bad, or if they need to be on meds, or what this means for them. It can be very, nerve-wracking for patients. And I think it's inappropriate that that we do that to people,
Yeah. I agree. I actually have a story of a patient, that exact thing happened to him. And he came in with a printout of his lab work that he had done a couple weeks prior, had not heard back from the physician because truly everything was okay. But he had in his CBC, so in his blood draw, one of his blood draws, he had his percent neutrophils were elevated, which is just like the percentage of a certain white blood cell was high. And he had Googled why, he had basically come in because he thought that he might have some sort of leukemia or cancer. And the reality is it's completely normal and completely fine. But because it showed up as red or bolded or high on the read, it led to this Googling, and cyclical nature of what we do when we think something's wrong is we try to figure it out ourselves. So I agree with, it is interesting. Like I agree with you in that if patients have access to their charts, we run into an issue. But if patients also don't have access and then physicians don't have the capacity to follow up, then what's the point of getting lab work done? So yeah, that to me always, it didn't feel like there was like a system in place that was formal and like structured. It always just felt like there was kind of this like, sure, go get lab work and then we'll follow up later. But I'm like, okay, what does that mean? Like, are they going to come in formally and talk about the results? Are you just going to message them if you see something abnormal? I don't know. I just had a hard time with that.
Yeah. And I'm sure you weren't the only one. I'm sure a lot of the patients left and they're like, wait, what's the plan again? How am I supposed to? Yeah. I think it can, especially because when you're in the doctor's office, and I'm the same way as a patient, when I go into a doctor's office, my brain just scrambles, I'm sort of like in this weird role of being the sick person or being the, person who needs help from a doctor. And I sort of like hand away my authority. I mean, I have to fight that, right? But there's a lot of different ways in which people are patients. And I think in many cases, they sort of forget to be in the driver's seat while they're there. And then 2 days later, they're like, oh yeah, I have this paperwork. What did it say again? And what am I supposed to do? And what's the next step? I don't know, my chart and check, and oh my gosh, do I have cancer now?
Right. No, seriously. Yeah. So that was a bit shocking.
Yeah. So how did the family doctor scene? I kind of want to just like take the pulse of my peers out there. How are they doing? I mean, I'm not in practice in a hospital anymore. I know what that was like and I don't miss it at all. How are they doing?
I think every individual I could tell was such a thoughtful and like caring. The attendings within family medicine, I just think had a certain aura of like kind of like mama bear, just like wanting to be very caring and thoughtful. But at the end of the day, there's no doubt they just seemed and felt so rushed and flustered. Like and not in a way that I think was outwardly apparent to the patients at all. I think it was just, between finishing your notes too, like to not have to go home and say they're seeing patients every 15 minutes.
Mhm.
We could see 10 patients in the morning, 10 patients at night. Because you're just going one after the other, you still have to write a note for each of those patients. So then, they're leaving the end of the day having 20 notes to have to complete. And so they're also trying to do that in between when the student is in the room. And so it honestly just, everything just feels like it's spinning a bit, to the point where I think you just kind of lose out on humanity and like lose out on really like remembering why we're doing this and like who it is in the room, and it's just a human and they want to be cared for. So long-winded answer is I felt like they were amazing people, truly, with great hearts and great intentions. I think that they just seemed very, very confined to a system,
Mhm.
unfortunately.
Mhm. Sounds about right. Sounds about right.
Did you feel that how long were you in the hospital setting? Or were you in the hospital, or were you in like a clinic setting within a university?
Not within a university, but within a teaching hospital. So I
Okay.
was faculty within the hospital that I trained in as a resident. So that was Lehigh
Okay.
Hospital. And I had sort of a mixed role because I was faculty and I was precepting, which is teaching, being an attending and teaching residents, not so much teaching medical students, although sometimes a medical student would shadow me in my own day-to-day. But that was with the residency within a kind of hospital-based kind of clinic adjacent to the hospital.
Mm-hmm.
I
Yep.
also had a role as an attending in the underserved, medically underserved clinic that later became an FQHC, Federally Qualified Health Center. So I was an attending there as well and had my own practice there eventually. So I had this kind of, not really in the hospital for that second piece, but in the hospital
Mm-hmm.
for the first. I never was an attending on the ward, so I never rounded, I never did inpatient family medicine, which some of my
Mm-hmm.
colleagues did. Although I did deliver babies in the hospital when I was still doing
Mm-hmm.
that. So it was kind of a little hybrid.
Yeah.
Of,
Okay.
um,
Did you feel those sort of pressures too? Or did
yeah.
you feel like you had more time? Is
No,
this
I
like
mean,
an evolving thing?
I was working for Lehigh Valley, like sort of during this transition time. I think I was at the tail end of their willingness to reimburse teaching faculty, of which I was one, for just on a salaried basis, like without any kind of requirements to meet RVUs, which for those who don't know
Mm-hmm.
what that is, it stands for relative value unit, I think. And it basically, do you know about RVUs? Have you heard about that?
Mm-mm.
Yeah, you're a little bit exempt from them as med students. You don't really necessarily need to know until you get into residency. You'll start to hear about it and in practice, obviously. But it's the way in which the insurance companies and hospitals or clinics work together to determine what you're going to get reimbursed for a unit of work. It's essentially a unit of work.
Mm-hmm.
Um, and most places reimburse doctors based on the units worked as opposed to on retainer or salary, just show up and, be whatever is needed for however long it takes to do the work. So this is where documentation has a lot of different roles. Like it's important because you tell a story that other colleagues can read and the patient can have access to understand that we're all on the same page about the story, the narrative of this person's health journey. But it's also really important for getting paid by insurance companies. If you're, dealing with insurance companies, which most, almost all hospitals, I would imagine in this country, other than boutique ones, maybe are dealing with. So you have to be able to demonstrate you've done the work and you've done what you said you've done, and you therefore can get reimbursed an agreed upon amount of money based on your RVUs or your basic
Mm-hmm.
productivity. It's a way of measuring productivity. It's a terrible way of measuring productivity because how do you define, what do you really, who's deciding what is productivity, what is, a good outcome? Are we looking
Mm-hmm.
at just whether you asked a question about if someone's a smoker or not? Because if you don't check that box on the chart, you don't get paid for asking that question. So that, there are certain things that seem to be valued higher than others. Did a person leave satisfied? Did they have all their questions answered? Did they feel seen and heard? That's not measured. So for people like you and me who care about making sure someone feels seen and heard and valued and, under and empowered around their own narrative and what the next steps are, in our shared decision making about what our next steps are, that conversation takes time, time to build a relationship. It takes time to, invite those tough questions, and it takes time to work to a consensus with your patient. And that stuff's not really reimbursed or reimbursable. So what it means is you're often doing that on your own time, taking extra time that isn't sort of allotted to you in that 15-minute visit, in order to meet the needs of the patient and to your own integrity, really.
Yeah.
So I think there's, I guess all that by way of saying that it takes time to deliver care that feels human and, worthy of reimbursement and worthy of the person in front of you who's just invested time with you and is coming scared and vulnerable and seeking information or support. So yeah, I think it was really hard for me to work in that system. And yet I took extra time. I was always late because I was always spending the time that I felt was needed to do the right thing. And I was, and it meant that the person who just waited an hour might get an hour with me, so people knew. It still wasn't cool to be like making people wait. But on the other hand, I didn't know how to do it otherwise. I couldn't figure out how to deliver care in a way that really felt caring and complete in 15 minutes. I mean, very rarely somebody would come in who had like a super simple, straightforward problem or needed a sports physical and they were totally healthy. And then I'd be like, okay, I would love to spend an hour with you as well, but I'm going to crank through this visit in 12 minutes because you need, and you know what I mean? And then it'll save time for someone else. But yeah, it was really hard. I mean, it's why I do now. I get to spend, as much time as I need with people, and usually, and usually have time to, make sure we have our labs before that happens and all the things you're talking about to make it really effective and efficient for people. So that's make it really, really valuable for people.
Yeah. No, I makes sense. I mean, the lab thing is crazy to me because it really informs so much of the conversation, especially the labs that you get, because you get much more comprehensive labs than, just cholesterol levels and LFTs. But it's just almost funny to me, be like, how do we know how this patient, like if we don't know their hemoglobin A1C, do we know if their diabetes is well controlled, or do we need to adjust their medications? And I guess that conversation just happens afterwards. But it's hard to counsel someone on a new medication or an adjustment in their medications or the reasons behind, why medications are needed to change over like a portal. In my eyes, I'm not the one doing it, but it seems a little bit challenging both on the receiving end and on the delivering end.
Yeah. Well, I mean, and the other thing to say, I guess, is you can always fill the 15 minutes with something else that often is more valuable to the patient anyway, like a conversation about how are you feeling about the fact that you're now on diabetes meds, or how are you, feeling about the fact that your kids just graduated from high school and you didn't think they would, or, you can develop relationship in that time too.
Yeah.
And then the labs can happen later. Just come back.
Yeah. Yeah. True.
Yeah. Cool. Anything else that wants to be said about the family medicine experience, including like why you're not going into family medicine?
I think for me, I just ended up feeling like it was just getting repetitive, and I wasn't as, I like to use my hands and I like things to be, pretty intense at times. I like the kind of ebbs and flows that come with more like a higher intensity. But to be honest, I think there could be a counter argument to that, of course, and that is that like each patient was different. So repetitive is not a fair choice of words, because I think every patient had their own unique complaint, their own unique situation. I think the problem for me became when, like, yes, every patient had their own unique complaint, but we have about like I felt like there were like 4 lines of treatment that we were going to follow. Like if they fell into this bucket, we were going to give them metformin. If their hemoglobin A1C was above 6.5, we're going to give you metformin. If your blood pressure is elevated and you're already on an antihypertensive, we're going to add, this calcium channel blocker. But if you're not on a blood pressure medication, we're going to do that. And so I don't know. I think it just felt like it was very streamlined. And for me, it didn't allow for as much creative thinking or like really getting into the weeds or using my hands. And so that for me was probably why it was not the choice for me.
Let me ask you a follow-up question then, because I know you have a background in elimination diets, for example, and how important meditation is and, exercise. Did you ever get a chance to broach any of those topics with patients? Did you feel permission to talk about things that I know make a difference in people's lives?
Yeah, I really did try. It was interesting because in that time where I said, you go into the room and it's just myself and the patient, and I introduce myself as the medical student and that the doctor will be in shortly, because sometimes people are like, oh my gosh, really? I've been waiting for an hour and now you're making me see this, you. And so anyways, but during that time, if I had the opportunity, because I knew once the doctor came in, I wasn't going to be talking. And so if a patient was talking about like indigestion or symptoms, like symptoms that sounded very inflammatory, or they're having this brain fog, that was when I really jumped on the things that I knew when it comes to like inflammatory foods or what they're eating or how are they sleeping? Are they spending time doing any sort of mindfulness meditation? If they're talking about anxiety or mind racing, I did try to use the tools that I currently have, which I don't think are necessarily super vast yet. But I do think I have some knowledge. And I will say there was one patient who had been saying, I think I have some sort of insensitivity or some sort of sensitivity to gluten. I have had a really hard time stopping, like avoiding it, because it seems like it's in everything. But I think it's what's causing it. And we chatted for a very long time, and I shared with her my journey and my experience eliminating gluten from my diet and what I've noticed. And she left the room and she's like, you know what? I think God placed me in this room with you to tell me that I need to stop eating gluten and that it is possible and it will help me. So I was like, okay, well, that seems like one person that we're not just giving, a PPI and saying, oh, you probably just have acid reflux, you'll be okay. But yeah, I did try. It was hard.
What was that like to be called an angel?
I was like, well, I think it was very sweet. I think it was fun to just be able to like connect, because most of the time I feel like the patients we saw was like it wasn't the demographic that was like really looking to hear about what I had to say about meditation or eliminating fatty, greasy foods from their diet. And I tried to read the room on that. I would give my, the recommendation is 150 minutes of aerobic exercise, and that can include, brisk walking, to try and like emphasize physical movement, because I think having a goal of just getting moving, it can be, and making sure they know, can be the freedom of any sort of movement. I would start there. If there was already resistance to that, like the diet stuff, I would sprinkle in. But sometimes I think there were moments where I was like, wow, this person has absolutely no interest in learning or hearing about the fact that, if they reduce the amount of inflammation in their gut, they'll probably feel a lot better.
Yeah.
Which was hard.
Yeah. Yeah. Asking people to change their diet or even mentioning it can be very triggering for some people. Sure.
Yeah. Yeah.
Wow. Well, you've had a full year of the smorgasbord of medicine. What are you looking about your 4th year and your electives?
This past year has just been so eye-opening about this amazing field that I have the privilege of being a part of. I think it's, there's absolutely problems within the system, but there are ways to, and you've proven it, there are ways to carve your way into something that you feel you're doing right, and you're serving the population that you need to serve. And so as I look ahead, I think this past year has been like a really great year for building a wide and very shallow foundation. And now I'm ready to start building some depth and like really digging into the things that are going to serve the people and population for which I will be providing for. I want to start to like build that expertise. And for me, what that looks like is like really leaning into what my role is going to be as an OBGYN. I think electives are going to be a valuable time to explore things like ultrasound. I think ultrasound within OBGYN is critically important. And for me right now, like I have had no training in ultrasound, and to me, everything kind of looks the same, different shades of gray. So that's an elective I'm doing. I'm doing a breastfeeding elective. So being able to counsel new moms on lactation and latching techniques and things like that. And then obviously I'm doing like hospital-based OBGYN, so maternal fetal medicine, dealing with high-risk pregnancies, just learning more about what it is that I'm excited to be going into is probably what this year is going to bring. It's kind of like, I relate it to your 4 years of college, at least for my experience. The first 2-3 years, you have to do all the like general requirements and you're seeing everything, but then you finally, like the third and fourth year, are able to start really digging into your major and taking the more like nuanced classes that are very specific to whatever your major is. And I feel like that's where I'm finally at in this medical school journey. And it's exciting because now, I get to really lean into the things I'm passionate about.
Awesome. Anything that's wild and out there that you're like, this maybe has no relation whatsoever, but I can't keep myself from it?
Okay, so actually my schedule's been all kerfuffled because I am applying to these away rotations and I'm having to move things around. So I was just looking through the catalog, and I haven't officially signed up for anything that's, completely out of the ordinary, but I could have the opportunity to do something like learning about urology or radiology, or doing like, I'm going to do an emergency medicine rotation, but I can do something more specific in like the ICU, which I think would be really interesting. And just not that it wouldn't be valuable as an OBGYN. I think any sort of medical knowledge is always going to be helpful, but I haven't officially signed up for anything. Did you do anything out of the ordinary, or that you can remember from your fourth year?
My fourth year was radiology and dermatology, and I did a psych consult liaison in hypnosis. I did, that was really fun. And I did I did an away rotation in Lake Almanor. Can't remember the name of that place. It was like a 2,000 person village hamlet at the base of Mount Shasta, which had like an 8-bed hospital run by the family doctor who I shadowed for a month in Lake Almanor. So and she got me lodging. She's like, oh, whenever we have med students, I just hook them up with, Grandma Dorothy, Grandma Higby. So I ended up staying with this woman who was a delight and had traveled all over the world and had such interesting stories. And I took my husband and my 2 oldest kids, so my boys, Mahlon and Baxter, went, put Mahlon in a camp, put Baxter in daycare where he basically just sat there with his passy all day and watched everybody. And I had a wild adventure and, went to the lake every afternoon and went to Mount Shasta on the weekends. And yeah, that was super fun.
What was Greg doing during the day?
Working remotely. He was working at Stanford at that time. And so he had a job where he could do, it was also summer. It was like in the summertime.
Okay. Yeah.
Super duper fun.
Wow. That's crazy.
I also did, this was great. So I did a rotation with my uncle, who's a family doctor in a small town, California. I did like 2 weeks with him or 1 week with him. I did a rotation with my dad, who was a practicing
that's
surgeon.
amazing.
He got retired, but he was a practicing neurosurgeon at the time. And that was such a delight. I got to shadow my dad. And, I grew up whenever we went in public growing up, there would be people who would accost us and be like, "Oh, Dr. Brian Clegg, you saved my husband's life. How's he doing? Oh, he's dead now, but you were so wonderful at the time. And, 20 years ago when you were caring for him." And people just loved my dad. And it felt like it was such a gift to kind of watch him in his element in the final years of his career doing his thing with his
That's
patient.
so cool that you got to do that. Yeah.
It was really special,
Wow.
magical.
Oh, that's amazing. I am doing an integrative medicine 4-week elective at our, we have, GW has a center for integrative medicine with Dr. Kogan. And so I'm going to be doing that, which I'm really excited for.
Very fun. I want to hear all about that, what their career.
Mhm.
That's really cool. So
Yeah.
one last question for you. I got a text from you one night as you were finishing your rotations, and you basically said, well, you said a lot of things, and I don't need to hear the part you said about me, but I want to hear what you said about medicine in that text. Do you remember?
Yes, because I had been, was I listening? I was reading. We had this like humanitarian, like I feel like we had this humanitarian lecture and they had given us a reading. And at that point in my journey, I was feeling rather discouraged. I was feeling as though in my childhood, I had always viewed doctors as these thoughtful, caring, selfless superheroes. And I had viewed them with this lens of, I just had idealized the role. And I was eager to join that amazing group of individuals. And in my 3 years, I feel like I've just been exposed to a spectrum of doctors, of quality of doctors. And to me, that it just went against what I had, this notion and this perception that I had created in my head about what it was to be a doctor and what I thought that everyone would feel as a doctor. And I think I just during that time of this journey, I was just frustrated by the number of times I had just been disappointed by an encounter or how a doctor was talking to the patients or the amount of time they were giving them or how they were treating them. And so in that moment, I was like, wow, having a good doctor is such a gift, and having a great doctor is incredibly rare. And for someone to have a connection with their doctor and feel super loved and cared for by them, I think is life-changing. And so I had reached out to you because I think that you are that role for many people, many of your patients. I think you have created a space and environment that is safe, that is welcoming, that people feel heard and seen. And when I see that, which I don't get me wrong, like I have absolutely seen some amazing physicians in their craft and been in awe. And when I see that, it honestly makes me feel so much joy. So I think the reason I reached out is I just was honestly like, thank you. Like, thank you for keeping that spirit that I had as a kid alive and like reminding me that still exists. And, there are plenty of doctors like you who, genuinely care and are there to listen and support every need, not just the, pervading need, but every need of the patients. And yeah, I wish I could bring up the quote because I actually would like to share it because I think it's something that I would like to remember selfishly as I listen to these in my later life, maybe when I'm an attending and feeling quote unquote burnt out, I have it here if that's okay.
Yeah.
With you. Okay. So the quote is, "Not every patient can be saved, but his illness may be eased by the way the doctor responds to him. And in responding to him, the doctor may save himself. But first, he must become a student again. He has to dissect the cadaver of his professional persona. He must see that his silence and neutrality are unnatural. It may be necessary to give up some of his authority in exchange for his humanity. But as the old family doctors knew, this is not a bad bargain. In learning to talk to his patients, the doctor may talk to himself back into loving his work. He has little to lose and much to gain by letting the sick man into his heart. If he does, they can share, as few others can, the wonder, terror, and exhaustion of being on the edge of being, between the natural and the supernatural." And I thought that that was powerful because I think it is very easy to lose your humanness, your humanity in this process. And I just want to remind myself that, allowing patients, like it says, into your heart is really not only how you transform and help and shape them, but also how you maintain and sustain yourself too in this process.
So well said, Meghan Tveit.
Thanks.
Yeah, thank you. You're a wonder. It's such a beautiful thing to be able to catch these little downloads from you as you climb the ladder.
I'm very grateful to have these in the back pocket that I can listen to and turn to when I'm needing a reminder about what's all going on in this life. So thank you for having me and letting me share my stories and my experience in my medical school journey.
You're welcome. I hope you enjoyed this episode of the Healing Grove podcast. If you liked it, please be sure to like and subscribe. And if you want to deepen your experience further, consider grabbing a copy of the Healing Grove Playbook. With journal prompts for this podcast and 41 others, it's the perfect place to record your learnings, keep track of the tools you explore, and reflect on your own experience. Finally, it's important to mention that even though I am a doctor, nothing you hear on this podcast, whether from myself or my guests, constitutes medical advice. Any intervention you try should always be discussed with and supervised by a trusted member of your own healing team. Thanks for listening, and see you next time in the Healing Grove.